Welcome to State of Reform's virtual series, 5 Slides We're Discussing, with some of healthcare's most thoughtful leaders. And now, the host of State of Reform, DJ Wilson.
Hello and welcome to another edition of our virtual conversation, 5 Slides We're Discussing. This is part of our effort here at State of Reform to continue to bridge the gap between the world of healthcare and health policy, but do it in a distinctly COVID-19 sort of way. And by that, I mean, we want to continue to foster these conversations about community and about solving problems that we're all facing across silos and across demography and geography. But of course, do that in a way where we're not all crowded around a table in a convention hall someplace or in a hotel, but rather using these tools of the digital age to bring these conversations right to your desktop. So appreciate you all being with us. This is our second one of these 5 slides discussions, and we're really honored to have 3 of what I consider to be the most sort of thoughtful and innovative leaders in the philanthropic space. These are really folks that I admire either from far in watching them or having gotten to know them over the years. And I really am appreciative and honored that they have made time to be with us. So to that end, we have Sarah Lyman, the Executive Director of the Untitled Health Foundation out of California. Sarah, thanks for being with us.
Thank you for having me.
Yeah. Elena Marks, the CEO of the Episcopal Health Foundation out of Texas. Elena, thank you for being here with us.
Glad to be here, thanks.
And a few time zones away from Harris County in Texas is Steve Williams, the Chief Operating Officer up out of the Alaska Mental Health Trust. Thank you, Steve, for joining us from Anchorage.
Thank you for the invitation and happy to be here.
Yeah. So let me talk for a second about how this will work and excuse me, and some of what we're trying to achieve here. With this tool, this virtual conversation platform that we are using today, we are hoping to continue to build and foster an interactive conversation. So you'll see the opportunity to ask questions on the right. Please use that for comments or things that you would like me to convey to our panelists. If you see a question that you think is worthy of discussion, you can upvote that. That will elevate the conversations, or rather it will elevate the more interesting topics that you think are worth asking up to me, and I'll convey those. The idea of our conversation today is to go through 5 slides that our panelists and folks that are on our team at State of Reform think are really some of the more interesting and more compelling conversations that we ought to be digging into. As we go through this and as you sort of learn with us as audience members, we'll have a survey at the end of this event, which I'd love for you to respond to. We're using this tool and this experience to continue to iterate as we build a platform for virtual conversations that we'll be hosting this fall. So without further ado, let me just sort of jump right into it. Elena, tell me first about the Episcopal Health Foundation and the work that you guys are doing out of Harris County and in Texas.
Sure. So we are almost 7 years old, and we are what's called a conversion foundation. So we are the product of the transfer of a hospital system that took place in 2013. We are based in Houston, Texas. We cover 57 counties in central and east and southeast Texas, about 12 million people in our 57 counties. Our corpus is $1.3 billion, and our mission is to improve the health and well-being of the people in these 57 counties, with an emphasis on low-income, vulnerable, and underserved populations.
$1.3 billion, that's real money, even in Texas. Steve, how about you up in Alaska? Tell us about the Alaska Mental Health Trust.
Sure. The Alaska Mental Health Trust is a state corporation. We're a public entity that was formed out of a lawsuit against the state of Alaska back in 1982. We just celebrated our 25th anniversary. Our mission, our focus is Alaskans who experience mental health issues, substance use disorders, developmental disabilities, Alzheimer's, dementia, other related cognitive impairments, traumatic brain injuries. And we have a policy as well as a funding focus. We operate like a private foundation. We grant out over $20 million a year within the state of Alaska to local governments as well as nonprofits. And our goal is really to ensure that those populations that I mentioned have access to a continuum and equitable healthcare system.
Yeah, great stuff. The trust has been a central player in Alaska healthcare and health reform for a long time. So thanks for being here, Steve. Sarah, how about the Alliance Health Foundation down out of San Diego? Tell us about what work you guys are engaged in.
Sure. So we are a private health conversion foundation. We serve San Diego County and Imperial County, about combined population of about 3.5 million. We're focused on improving health and wellness for vulnerable populations in those regions, both as a grant maker and also an active impact investor. And we support a lot of innovation and nurturing of innovative ideas, as well as core operating support and investments.
Yeah, good. And I got to say, you know, there are a lot of different types of philanthropies in healthcare, but each of these organizations, each of you are really doing work that is, I think, data-driven and leading to scale that's having measurable impacts on the healthcare system. One of the reasons I like to host this particular conversation is because I think that philanthropic interests have been filling the gaps in a lot of ways. They're seeing things that people don't always see in the healthcare system and making meaningful changes in ways that don't always show up. Well, they don't always show up on headlines, but they show up in a meaningful way in people's lives and in the healthcare system. So let me ask each of you sort of this question. This first slide that we'll turn to is a slide of the effective reproductive rate of COVID-19 across each of the states. The reproductive rate is the rate, the number of people that each infected person can be expected to infect while they are contagious. So the goal is to have a reproductive number under 1, which most of the states fall in that category today. This changes very rapidly depending on the dynamics. Each of your home states are there, and of course your states are big and diverse in different ways. Sarah, let me ask you this question first, though. What are the data points that you are looking at? What are the data points that you're keeping an eye on when you are thinking about how to fill some of those gaps in the healthcare space as a result of COVID? The trends that are happening right now, the data points that are happening right now, what are you watching?
Yeah, I mean, this is such a tricky balancing act. I've been really impressed with our state and local leadership on trying to navigate the complexity of preventing public health transmission of this virus while also being mindful of the economic disaster that's being caused. So, you know, I think I would say our leadership is doing a really good job, and they're looking at sort of 3 core data points in particular for counties to be able to reopen more quickly and kind of spur economic development. So those are, county case metrics, looking at like stable hospitalizations. They're hoping to find, areas that have no more than a 5% change in a 7-day average, or less than 25 new cases per 100,000 people in the last 14 days. County preparedness around the 3 T's: testing, tracing, and treatment. How our hospitals can handle, a surge. And then also the county response, like how quickly are we able to get communications out to our stakeholders and modify our strategies as needed. So I think we're watching all of those things like the rest of the world, and I'm hopeful that we can avoid a surge, but I'm also worried because I feel like the reopening is happening pretty quickly, and there's a lot of reasons for that. But we also are in a really complex region, being very binational. We have a very fluid binational economy with Mexico. San Diego is an urban hub that relies on tourism. Imperial County is one of the largest sort of epicenters for agriculture, producing a lot of our food. So I think our risk is still fairly significant, and that worries me.
Yeah. Steve, how about in Alaska, big state, 2/3 the size of the United States by land mass, 700,000 people in the state. Your Governor Dunleavy, has effectively reopened almost entirely, soon to be entirely here, if not now, pretty quick, across the entire state. I think June 2nd, there are a couple of other deadlines coming up, but as you all in Alaska are thinking about reopening the economy, you've got very low numbers. What are you watching? Are you more concerned about economic impacts at this point, or is public health still a primary concern at the trust?
I think we are concerned of both. One of the things that really is out there that is concerning is a lot of our population is off the road system. So access to healthcare, immediate healthcare, is challenging. And so really paying attention to what happens in what we refer to as rural Alaska, to make sure that we contain, to the extent possible, the spread of COVID is important. Related to that, the Trust is really paying attention to what's going on in our nonprofit healthcare sector. The healthcare sector in Alaska is provided by 51% of the sector is nonprofit. So paying attention to the health of those organizations, both from a financial perspective, but also how they've had to adapt in their service modality, and helping to help them make that transition as we enter this new phase of healthcare and the delivery of healthcare.
Yeah. Elena, how about you? You're both in Texas and in your service area. It's a large service area. Texas, obviously, a very large state and diverse state, border state like California. How do you sort of differentiate, or what are the things you're watching across geographies and across demographies? Austin is different from Houston, and Amarillo is suffering in a way that El Paso is not. How do you make sense of the data when you have such a large, diverse state and economy?
Well, we try to look at it region by region, because what is going on in one area is not necessarily what's going on in another area. We try to pay attention to the same data points that Sarah talked about. The state actually has a reopening task force, and it used some of the standard markers from public health experts about when the state should reopen. And even though none of those metrics have actually been met, the state is reopening and on an increasingly fast pace. Some of the local governments are trying to put a damper on that because they fear that we will have spikes, that the fact that we have been as fortunate as we have to have a relatively low caseload and to still have capacity in the system, there's a belief that that's because we did take sheltering in place seriously for a while. And there's a lot of concern about reopening too quickly. We are following for our own office what our local officials are recommending, and so we are not reopened. But we are watching so many of our partners who didn't have the luxury of closing and working from home in the first place, who are reopening. And we're also extremely sensitive to the fact that so many of the people we care most about don't have the luxury of working from home or staying home or isolating at all. And so it's really complicated. I feel like Texas has been relatively lucky so far, with a few exceptions. And I hope we can continue that, despite the fact that some of the reopenings we have seen have involved very crowded places.
Yeah. Well, let's stick with you for a second here, Elena, and go to the slide that you have mentioned. It's sort of, I think your comments there about concerns in the state of Texas sort of segue well to some of what you've got here. Tell us about this slide that you've brought, what you think it says, and what it means for the Episcopal Health Foundation.
Well, I picked this slide because it animates what we do at EHF and how we approach improving the health and well-being from an equity perspective. And if you look at this chart, the data on the left regarding poverty is from 2000, and then on the right, the data is current COVID data. And I chose this because what you see is 20 years ago, Black and Hispanic populations were disproportionately living in poverty. You fast forward to the COVID era, and you see that those same two groups are disproportionately impacted by the coronavirus. And what that tells me is that we have longstanding structural barriers in place that have prevented and literally held back certain communities from having the full opportunities that everybody wants, needs, and deserves for themselves. And so if there's any silver lining to me in COVID, it might be that this sort of data is unacceptable and people are looking at it again. And if you want to understand why white populations are doing better than Black and Hispanic populations in Texas, you have to look very deeply into all of the structures that are in place and understand that it's not just about COVID, that it's about the systems we have in this society that disadvantage populations over and over and over again.
Yeah, and whereas normally we would spend more time on this slide, Sarah, you have a slide that is similar or tells a similar story in San Diego rather than in Texas. Why don't you walk us through this slide that you've brought to the conversation, Sarah?
Sure. Yes, it's deeply related to what Elena shared. And while perhaps somewhat redundant, I think this message bears repeating. In the US, we've witnessed severe and growing income inequality and a stark racial wealth gap for decades. And we know that wealth, which includes savings, car and home ownership, and other assets, is a better indicator of economic security, especially as it relates to health and well-being, than just looking at income alone. And the racial wealth gap is even more dramatic than the income gap, and it persists across all comparative income levels. And then the map on the right just highlights how important targeted place-based interventions are going to be when you overlay the COVID-19 cases by zip code in San Diego County with race and ethnicity. You see that 8 out of 10 of the hardest hit zip codes and all of the top 5 have substantially higher proportion of minorities and low-income families than the county as a whole. So in the context of our current economic meltdown, we're looking back to what happened coming out of the 2008 recession, where we saw between 2010 and 2013, white families on average experienced wealth growth by about 2%, while Black and Latinx families saw their assets plummet by 34 and 15%. So, the disparity was less severe in the following 3 years, but overall, the loss for people of color was still much greater. So, a huge question on my mind is how do we mitigate or prevent a worsening of income and wealth inequality, and therefore multi-generational health and wellness disparities this time, especially given the scale of what we're seeing in our current economic crisis and in the midst of a rapidly changing economy and workforce demand.
Yeah. Steve, on the one hand, as we've discussed already, the Alaska experience with COVID is lower on a per capita basis and lower on an absolute basis. But these sort of struggles of demography and health outcome disparities across ethnicity, those are something Alaska has been grappling with for a long time in a lot of different ways. How does this sort of these data points about economic and ethnic disparities, how do you experience those in the Alaska experience?
That's a good question, DJ. And, I think some of the things that Elena and Sarah highlighted aren't unique to Texas or San Diego. And one of the things that jumps out in my mind as they were talking about these slides are social determinants of health. We've talked about wealth already. We've talked about access to healthcare, but there are other pieces of the social determinants that, can drastically improve someone's longevity and overall health. Things like access to housing, access to transportation. Those are 2 big issues in Alaska, and I'm sure they're the same in San Diego and Texas, that we struggle with given our geography, but also given our infrastructure in some of the more rural locations of Alaska.
I want to make sure that people who are on this conversation or in this conversation have an opportunity to ask questions. I look at the top of the Q&A section for those of you who want to write something, so that way I can see those items which have been upvoted. Michael Goldberg, who's one of our reporters, actually has the most upvoted question, and he's asking about the relationship between philanthropy and the traditional health systems. How has that conversation been going about traditional health systems asking for support from philanthropic organizations? Elena, what is that sort of financial relationship like in Texas between your organization or others and some of the healthcare system?
Well, for us, we use the tagline health, not just healthcare. And our take on health reform is that we need to be spending more time actually achieving health outcomes and less time on intensive medical procedures, that we have actually overinvested in healthcare delivery, considering what it can return. And we have underinvested in social determinants, as Steve was just talking about. And so we don't fund hospital systems. Sometimes we partner with them in certain ways where there's some community-based work that they're doing, but primarily our work begins with community-based primary care. We fund a lot of FQHCs, and we go upstream from there. And our work around healthcare delivery is really to make sure that it can actually deliver on health outcomes and not just deliver more medical services. And so for us, before COVID, during COVID, and after COVID, our relationship remains with the community-based providers and then upstream work from there.
Sarah, I know you at the Alliance Health Foundation, you guys are really trying to test and scale. You did that in your role formerly at the Empire Health Foundation as well. How do you bring a philanthropic investor's perspective to the integration of financing challenges from COVID, social determinants, and the P&L needs of your healthcare partners? How do you try to braid those conversations together in a meaningful way?
Yeah, well, certainly I don't pretend to have all the answers to some of these really complex questions, but it's something that's top of mind, especially because, I'm still relatively new to California and to Alliance, but Alliance does have a long history of supporting innovation, and in particular in ways that sort of help shift dollars and investments upstream from, sick care, so to speak, into prevention and wellness. And so what I've been thinking about a lot is like, what are the opportunities to advance, to link, workforce development with accelerated changes in our healthcare system, especially given the fact that we're going to see skyrocketing, unemployment and increased Medicaid enrollees with budget cuts to Medicaid. Like, that does not bode well for us. So are there ways to accelerate innovations in the healthcare delivery model through like telehealth or care coordination, for example, that could both serve as workforce opportunities as well as potentially tools to help reduce healthcare costs? Looking at like telehealth for homeless populations, for example, in ways that have been kind of hard to hack previously. There's new windows of opportunity now. And so I think philanthropy can play a really important role in piloting some of those, helping bear a little bit of the risk for healthcare systems up front to make sure they actually hold water. But similar to Elena, I think we're really focused on the social determinants of health and trying to get upstream a bit versus subsidize our healthcare industry in ways that are just not an appropriate or a scalable role that we could play.
Yeah. This question from Sarah Green, really for any of you that would like to try this. She asks about the actions people on the ground can take to help reduce the disproportionate impact on vulnerable populations. She asks, beyond financial contributions, are there efforts your foundations are undertaking that would benefit from the input or the tactical assistance from people working on the ground, either in healthcare or in community-based organizations or otherwise? Anyone want to take a crack at that?
DJ, I can start it off. When the COVID pandemic hit, and we in Alaska were looking at what is the role of a foundation to try and be a positive, stabilizing force as we develop the response. We and other partners that the trust engages with did surveys of the organizations that are providing services on the ground to vulnerable populations, and really sought their input for what they needed at the time, whether it was financial or other types of resources, to help them respond, prepare, and be able to maintain the service levels that they had been previously providing. One of the things that the trust did, and there are other foundations that have done similar things in Alaska, is provide some resources, either manpower or financial resources to get manpower to apply for some of the financial federal loans and state resources that are coming out to help stabilize these organizations.
Yeah, similar question for you, Elena. Let me ask, what would you like all healthcare providers and administrators, people working at larger institutions and of course, community-based organizations too, but healthcare administrators or providers, what would you like them to know that you think they don't know?
I would like them to understand the factors that have nothing to do with medical care that cause the conditions that they're treating. I think that most providers are aware, and they're often very frustrated because their tools are limited. And I'd like for them to be active in forming the kinds of coalitions and partnerships and financial arrangements that actually pay dollars to solve root cause problems, as opposed to continuing to do whatever it is that they do. We talk to doctors who are frustrated. They see a kid with asthma who comes in repeatedly. The kid's insured. They've got all the medicines they need, but they're living in an apartment full of mold. We don't have a system that will pay to fix the mold in the apartment, but will pay to have the kid go to the hospital and go to the doctor and go to the ER over and over again. And I think that we have providers who are frustrated with that. And as we look at payment reform and really paying for value, we have an opportunity for providers who are getting the most of those dollars to really use them to deliver value that's more than just medical services, but that actually solves problems that originate and can only be solved outside of a medical setting.
Sarah, I want to go back to your slide here for a second. Not everybody may know the map of San Diego County here, but the long and the short of the San Diego and Imperial counties is that there's a lot of money and there's a lot of people near the water in San Diego, and there are not a lot of people out in Imperial County. It's a very rural county, as you know, obviously. How do you think about the solving these problems across the geography? In other words, I'm actually specifically interested in the rural setting. In the rural communities where we have brain drain, where we have economic drain, where some rural communities have not yet fully recovered from the last recession, how do you think about serving those communities in a sustainable way that is not just giving them more money? How do you build them up?
Yeah, it's a really challenging question, and actually one that we've been grappling with a lot lately. Alliance has been trying to support sort of standing up additional infrastructure and capacity in Imperial County that provides more sort of local ownership and governance about, like, you know, the old saying of go to the people who have the problems, they know best the solutions, right? And so really trying to provide a platform for that through the establishment of a new endowment, essentially, that we would just sort of shrink ours and help staff one. The interesting challenge, though, and it sort of goes back to this whole conversation around disparities, is you know, there's inherent, and especially I think in rural communities, and Imperial is such an interesting community because there's this thriving and you know, enormous agricultural industry that provides, like, I think like 90% of our country's winter vegetables. Don't quote me on that, but it's a significant amount. And yet we see these massive disparities from, you know, the farm worker communities and immigrant communities with, you know, asthma rates and diabetes and, you know, unemployment. And so there's sort of like these inherent power structures that may not be intentional, but are certainly active and contributing to those disparities. And so, like, how do you also preserve the ability to support kind of like opening up the conversation around equity and, you know, while still supporting that real local ownership and governance of decision making? It's a tricky question that we've been wrestling with a lot.
Yeah. Steve, let's jump into your slide here. It gets into sort of explaining your strategic and programmatic focus. Why don't you walk us through the slide that you've brought to this conversation?
Sure. And I've spoken or alluded to some of this already. When this particular crisis hit Alaska, it actually, a year and a half previous, we had an earthquake in South Central. So Alaska was hit, South Central Alaska was hit with another unexpected crisis that we needed to respond to as a community. And when that happened, the Trust and several other of our philanthropic partners started looking at how do we work together to meet the needs, the immediate needs, but also help bridge the crisis through till other infrastructure, other supports from state, local, federal government could come in and stabilize. And so when this happened, we already had this sort of strategic lens. What can we do now in the immediate? But then let's also keep the eye looking forward, because we know this is going to be a drawn out process. One of the things that philanthropy has as a tool is its ability to be flexible and to be responsive. So I mentioned, getting information from grantees, from providers to hear what it is that they need, and then being able to adjust our work, our funding, our resources to adapt to those needs. And doing that, we pulled together other partners that typically we would work with on other large projects to see how we could band our resources together so that we were being efficient, we were being effective, and we weren't duplicating sort of efforts either on our own end or, more importantly, on the end of the community, because we know they are already stressed with a whole bunch of other things that they didn't see coming down the pipe. So that's what I was talking about when I said key crisis response elements. And by doing that, it really does help to create system stability. It helps to try and maintain the access to important health care. One of the things that the Trust is really concerned about, and I think it's starting to pop up in the news, is access to mental health care. And then helping organizations to adapt to the environment around them.
Yeah. Let me stick with you. That's good stuff, Steve. Let me stick with you on this question about telehealth that comes from Mike Hatzenbaylor. Hopefully I'm saying that right. I'm sure I'm not. But he asked about the increase in the use of telehealth. And essentially, to paraphrase, are we going to be able to keep around this flexibility that we have to pay for telehealth in the post-COVID space? And how are philanthropic entities thinking about that? Let me ask you, like I say, Steve, because telehealth has been a little more part of the ether in Alaska than in other markets. It still hasn't fully, it's still exploding now in Alaska in a way that it took COVID to catalyze. How are you thinking about the role you might play to support the continued expansion of telehealth in this space?
Yeah, DJ, you alluded to it. Alaska has been using telehealth technology for years. Many of our tribal health corporations, tribal health providers have been using telehealth because that's the way they can provide the service from community to community when there isn't a road system. The way that I see philanthropy and the Trust kind of continuing that work is helping to adapt some of our more traditional urban setting healthcare providers to use the technology to do the outreach. And I think one of the key variables and questions will be, will the reimbursement rates, will the structures that are allowing for the use of telehealth now be maintained post-crisis?
Sarah, Elena, do either of you have thoughts on how philanthropic engagement or interests might continue to propel telehealth and catalyze it moving forward?
Sure. So Texas has only recently really released all of the restrictions that kept telehealth from spreading as broadly as it might have. In COVID, we are seeing a lot of grantees having to pivot to telehealth, whether they're in direct medical services or some other kind of client-facing service. And what we're trying to do is fund that piece of the pivot for them. We are concerned with reimbursement, but we're concerned actually on both sides. And there's a potential that telehealth will increase total healthcare spend, and we can't afford for that to happen. And so I'm really watching to see how we will allow and encourage and expand telemedicine, but not say now we've just doubled the capacity and therefore we've doubled all of the costs. And I think that the role philanthropy can play in that is the same role we played in trying to advance telehealth in the first place, and that was advocacy and data. And we produce information that is intended to inform policymakers so that they can take those things into account. So yes, more telemedicine, but we can't afford to increase total healthcare costs just by doing more telemedicine.
Sarah, I'll let you take that telehealth question if you'd like, but I also would like you to speak to a question from Melinda Freeman about how you in California have thought about utilizing or funded community health workers or folks who have a deep cultural competency and who can provide healthcare services to their communities. How does that community health worker piece fit into the Southern California experience?
Sure. Well, just briefly on the telehealth piece, I think it really underscores a point that Elena made earlier when you asked about like what's one thing that you would want providers to know or to think about. You know, we've been struggling with adoption of telehealth and the digital divide for decades. And the moment there was financial incentive to fix the problem, we kind of fixed it pretty quickly. And so I just think there's a value, we need to align incentives across the board. So that's just my only additional comment on telehealth. Yeah, and in relation to community health workers, I think we have made some investments in sort of the neighborhood networks, navigator type models and community health workers to do outreach work that's really deep embedded in hard to reach communities. And I think there's a really interesting opportunity to think about, like, we have this increased demand for contact tracing as an example right now. Is there, like, can we, get folks into that work stream and then work towards development of a pathway towards community health workers or other outreach efforts that are essential in our work to really serve the underserved communities.
In our next slide, we have something of a Rorschach test. Nobody talks about that, use that term too much anymore, but this is a picture from each of your area media outlets of Memorial Day and the holiday down in Galveston and Anchorage and San Diego. Steve, let me ask you, what do you see in this picture?
Well, it was a sunny Memorial Day weekend in Anchorage. When I look at that picture, and for folks who are watching this is the Veterans Memorial down in downtown Anchorage on a park strip. I see it's sort of an example of what we as a country are struggling with right now. We want to get back to normality. There's this overlay of a pandemic that we really don't have a full grasp on. I see people wanting to be together to support one another. I see people who are trying to maintain some social distancing in light of all that. And then I also see people that are congregating as if we're back to normal, which I personally don't think we're quite there yet. I guess that's my initial sort of take on that.
Yeah, Sarah, how about you? What do you make of this? California's, I think they had about 2,900 new infections yesterday. That's a high number for California. It was an early riser, but then calmed and plateaued. But it seems like things may not be moving in the right direction there. What do you see in these pictures?
Yeah, I mean, to me, this just dramatically extends how long we're going to be in this sort of like contraction expansion world. And I think we're going to just see modified normal, and it's going to keep changing because this is what happens when we start to reopen. And, it's human nature. I understand why, but it's highly concerning. And I think it's in the long run going to be really challenging until there's a vaccine or reliable antibody testing and herd immunity for us to have really any, at least prolonged, normalcy.
Yeah. Elena, if it were just you and me and Governor Abbott, the Texas governor, and you know, a couple of glasses of wine or cocktail on the bar, and he asked you, he said, Elena, what counsel would you give me and other governors about how to balance the public health imperative with the economic imperative? How do you recommend that we try to thread that needle where every day that we stay closed is another day closer to poverty for some people, and every day that we open is a closer day to sickness for some others?
I think I would advise them to use facts and to use all of the facts. People can handle the truth and they want the truth. And as much as we want to think that this is behind us and we dodged the big one, I don't think we have. I think we can also ask our leaders to lead by example, whether that includes wearing masks or showing themselves in social distant meetings, things like that, I think go a long way. One of the things that we know from all the various polling that's been done is that most people really do believe that we ought to do some social distancing. And I think that people will do that if they have it modeled for them, and if they are encouraged to do it, actually more than if you say it's the law and we're going to throw you in jail if you don't do it. And that Governor Abbott could have it both ways, where he could say these are things that are allowed to open in this way, and he could then, instead of talking about just the woohoo, it's open, talk about those that are opening and using appropriate practices for social distancing and masks and washing and all of the other things. And so that you don't have to pit it as either we reopen or everybody gets COVID. It's not one or the other. And I think I would advise them to tell people the whole truth and to allow people to make their own decisions and give them the guidance to make those decisions, and be honest about what the consequences are for deciding to go be in a large crowd or not.
Steve, same question. You know, it's a big state in Alaska, but the population means that you're going to run into, population size means you are going to run into Governor Dunleavy pretty regularly, not the least of which, of course, is your role that gives you reason to do that. But what counsel would you give him about how to think about any next wave or second wave that may be coming as a result of opening?
To at least listen to his chief medical officer, Dr. Ann Zink.
Period, huh? She's become something of a celebrity in Alaska.
He's got a good team around him that can help guide and inform, and as Elena pointed out, provide the data to help navigate this. Even with the data, there are going to be, curves in the road that no one sees, and we're going to have to adapt to the best that we can.
It's interesting. Some governors really want to make sure they are seen as in control and in charge for a range of reasons. Governor Dunleavy in Alaska he's a Republican, conservative Republican, and falls, in line with most of the conservative national trends. But in this case, there was no ego involved. He stood out of the way and let his chief health officer really lead much of this in Annie Zink that you mentioned. That's a little uncommon, I think, isn't it?
I don't know that I'm not sure how uncommon it is or if it isn't, DJ.
I just think it's good. I mean, I think it plays well, right? He's not letting ego get in the way. He's listening to somebody who knows what she's talking about.
Yeah, I mean, this is a situation where you need to have faith and trust in your public health sector and your leadership in that sector to help navigate something that, is in their expertise and skill set, And B, no governor in the country would have expected this to be hitting their state in the variety of ways that it has.
Yeah. Sarah, how about when you think about this question of the second wave? And I think pretty much all, models suggest there will be a second wave. It's a question of whether it will be big and painful or small and mild. What do you sort of think about in terms of how that will create pressure and widen gaps? We've talked about income and poverty. Are there other sort of system level things that you really worried, cracks that might get blown wide open as a result of this wave of Medicaid beneficiaries coming, this wave of unemployment coming? Are there other topics that sort of give you pause?
Yeah, I'm worried about a lot of things. I guess I do, though, really think we have to be laser focused on these racial inequities that are just going to get exacerbated. Like, I guess I feel like I don't want to take my eye off that target because we keep doing that. It's like it's impacting everyone. And so we take this global approach, and we've just seen over and over in history that doesn't work, and it doesn't build back a more resilient economy or infrastructure that will prevent us from getting into the same situation in the future. So I just think that that's really where I've been laser focused in my own mind. Not to say I have answers and solutions yet, but that we've been grappling with. I think we need those targeted responses.
Hey, DJ?
Yeah.
Can I just tag on to that, because I think both Sarah's work and Elena's work are important, and the slides that they had illustrate something very powerful and very concerning, which is, we can talk about here access to healthcare using things like telehealth technology and making sure organizations stay afloat so that they can provide the services. But what those charts showed you are very structural things that are ingrained in our policy and our culture, that if we really don't address and move upstream as they suggested, the next pandemic, not even the pandemic, we're still going to have inequitable access to healthcare, which ultimately has impacts on families, our economies, and our country as a whole. And so I really appreciate Sarah saying, what she's really grappling with and doesn't want to turn her eye away from is some of that structural piece.
So let me sort of turn to you as all with this sort of final question, and Steve, let me have you lead off to just kind of continue to build on your thinking there. I think it's imminently self-evident that there are structural issues related to race and economy. I just don't think there's any empirical question about that. But I don't think that the healthcare system is often, or even community-based organizations and human and social services, they're not always thinking about those gaps in the structure and the things that are built into our society and way of life. What counsel would each of you give to the healthcare leaders that are watching, that will watch this, that will read the coverage of this at State of Reform, the healthcare leaders specifically, not public policymakers, not philanthropic organizations? How do you counsel healthcare organizations to try to grapple with this structural challenge?
I think Elena said it earlier. I think healthcare providers are aware of these disparities and these inequities when they see the child come in with asthma, as I think that was the example Elena gave. Where they struggle is, how do they have an impact at a policy level? And to answer your question, it's advocacy, which I just stole from Elena again. She said it earlier. There needs to be the data, the research, and the collective will to advocate for policy changes that are going to require time for people to see the positive impacts of those policy changes. I mean, that's the other piece to this dialogue, which is policy change takes time, and the impacts of that change in a population or an individual also takes time. So it doesn't necessarily mean a swift change means you see the impact on the population the following months, year, or 2 years out. And you have to trust that, and you have to track it, and you have to adjust if it doesn't go in the direction that you think it should have gone in the beginning.
Yeah, great response. Sarah, how about you? How would you counsel healthcare leaders, senior executives, people on the front lines, not just of care, but also doing the work of administration in healthcare? How would you counsel them to think about these structural disparities and inequities in the system?
Yeah, I mean, I would just say first and foremost, disaggregate your data by race and ethnicity and look for disparities.
Yeah.
And, you can make a lot of actions based on that data, but until we sort of become more practiced at using it, looking for it, they're just, these inequities are going to continue to persist.
Yeah, great comment. Elena, last word, counsel to the healthcare leaders who are trying to hold it all together during this time of COVID. How can they think about, get their heads around this challenge of outcome disparities and inequality inherent in both society and the healthcare system at large?
Well, first they have to understand it exists, and I think they understand in general, and certainly what Sarah said, they can disaggregate their own data and see what's going on in their own patient populations. One of the tools that hospital systems, nonprofit hospital systems, have available to them is the community benefit obligation. And at least in Texas, most of the hospitals fulfill that obligation by providing medical services. They don't have to do that. They can actually use those dollars to provide community development activities. And if they are interested and willing to move a little bit upstream, there are all sorts of opportunities in partnership with foundations like ours that you can do in the community that doesn't have a thing to do with healthcare, but actually benefits the community more than the diabetes classes that you're offering and more than the uncompensated care that you offer at the end. The other thing they can do, going back to advocacy, is they can advocate for public policies. They can go down to city council when they see in a neighborhood from which a lot of their patients come that the sidewalks are awful and a dirty industry is about to move in right next door. They can go to city council and they can advocate. They are powerful voices who are well respected, and that doesn't really cost anything, except you have to be willing to put your reputation and name on the line, and you've got to be willing to get out there and say, this community is mine, these people are mine, and I care, and here's what I can do about it.
Yeah, great stuff. Good stuff. People registered to listen to the topic of philanthropy and COVID, and I think they just got a graduate school seminar lesson in structural inequity and inequality in our system and how that translates to poor health outcomes and what they can do about it. Elena Marks, CEO of Episcopal Health Foundation down out of Texas. Sarah Lyman, the Executive Director of the Alliance Health Foundation in San Diego. And Steve Williams, Chief Operating Officer up out of Alaska at the Alaska Mental Health Trust Authority. Thank you all for being part of this conversation. This has been 5 Slides We're Discussing. It's part of a new series we've launched here at State of Reform. I really appreciate your participation. We'll send you a link so you can provide us feedback. We want to make sure that we're learning by listening, and really appreciate your engagement with us. Be sure to sign up for our 5 Things We're Watching, not to overuse the word 5. That's our email that comes out monthly in each of our markets, and we really appreciate your support. Thanks for making time to be with us.
Thanks, DJ.
Thanks for joining us in this virtual conversation and for your support of our work at State of Reform.